Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a really critical deep dive. We're tackling the hospital-based management of Guillain-Barré syndrome, or GBS, and this is, well, arguably one of the toughest acute syndromes we encounter in hospital medicine. It's an acute immune-mediated polyradicular neuropathy. That diagnosis demands incredibly vigilant, multidisciplinary care, mostly because the risk of rapid, life-threatening complications is just so high.
That's absolutely the core message we need to get across immediately. If there's one thing, one primary directive for any hospitalist, any emergency physician listening, it's this. Hospitalization is mandatory. Mandatory for all suspected GBS patients. The stakes are just. They're non-negotiable. We know the data shows up to 30% of these patients will progress. They'll develop respiratory failure requiring mechanical ventilation. So our entire approach from the second they hit the door has to be laser focused on early recognition, on the most intense monitoring protocols you can imagine, and crucially, timely initiation of immunotherapy.
That really sets the stage perfectly. So let's unpack the syndrome itself. GBS. Globally, it's the leading cause of acquired neuromuscular paralysis. When we think about the classic picture, what are we describing? Usually it's rapidly progressive, symmetrical limb weakness. And the really key diagnostic piece here is diminished or absent deep tendon reflexes. That's areflexia. We focus a lot on the motor weakness naturally, but variable sensory disturbances are also pretty common. This whole process, the progression, it typically hits its peak weakness, the nadir, within about 2 to 4 weeks.
And understanding the different types, the classification is really essential. It tells us about the underlying pathology, the likely severity, and ultimately the prognosis. Historically, the form we see most often, especially in Western countries, is the acute inflammatory demyelinating polyneuropathy, AIDP. That's often considered the classic GBS.
But those variants are incredibly important, right? Especially thinking about severity. We have the axonal variants, AMAM, acute motor axonal neuropathy, and AMSAN, acute motor sensory axonal neuropathy. Clinically, they tend to present with a much more severe, more acute, and often a longer lasting course of weakness.
Right. And looking at the epidemiology, GBS is rare, thankfully, but its impact is just huge because it's so severe. The annual incidence is fairly stable, somewhere between 0.81 and 1.91 cases per 100,000 person years. That's in North America and Europe.
Yeah.
We do consistently see slightly higher rates in older adults and also, interestingly, in males. But what's really fascinating is the geographical split in subtypes. AIDP, that's the main one in the West. But the axonal variants, AMAN and AMSAN, which are often more severe, arguably more destructive, they're much more common in East Asia.
So the message for us in hospital medicine is just crystal clear. Early recognition isn't, a nice to have, it's an absolute necessity. The clinical course can be so volatile, so unpredictable. We know from the big studies the need for mechanical ventilation eventually, or having severe disability right at presentation. Those are strong, independent predictors of poor functional outcomes down the line, and frankly, increased mortality.
It is a sobering statistic. Even with the best possible intensive care, even with timely immunotherapy, somewhere between 3 to 5% of patients will die. Tragically and critically, up to 20% of those who survive are left with persistent, often severely debilitating disability. This high rate of ongoing problems is exactly why GBS just cannot be managed outside a structured critical care setting, at least not until things have clearly stabilized, plateaued.
Okay, let's shift gears a bit. Let's talk about the core mechanism, the etiology, the pathogenesis. We know it's an immune attack, and there's almost always some kind of trigger beforehand. About 75% of GBS cases, they follow some kind of infectious event, usually within about 4 weeks before the neurological symptoms start.
And we absolutely have to highlight the main culprit, Campylobacter jejuni. This specific bacteria, it's responsible for roughly 30% of cases worldwide. And that link isn't just academic. C. jejuni-associated GBS, it's fundamentally tied to a more severe clinical picture, and specifically to those axonal variants, AMAN and AMSAN. So that connection immediately raises a prognostic red flag for the team.
What other infections should be on our radar during the workup?
Well, cytomegalovirus, CMV, is a big one. It's more often linked to the demyelinating AIDP forms and often causes more significant sensory issues. Other ones to think about include mycoplasma pneumonia, Epstein-Barr virus, and more recently we've seen Zika virus recognized as a trigger, especially in areas where it's endemic, sometimes leading to clusters or outbreaks of GBS.
So the mechanism of injury itself, it's this concept of molecular mimicry. It's quite elegant scientifically, but obviously destructive clinically. Can you walk us through how this immune mistake actually damages the nerves?
Certainly. So the immune system initially does its job correctly. It mounts a response to target the antigens from that preceding infection, the bug. But here's the problem. Due to structural similarities, this mimicry between the microbial antigens and components of the patient's own peripheral nerves, the antibodies and the T cells get confused. They cross-react. They attack the self. And the specific part of the nerve they attack determines the type of damage, the pathology we see.
Okay, let's follow that through. For the severe axonal forms, like AMAN or AMSAN, what's the specific target of that immune attack?
In those axonal forms, the autoantibodies, they often go after specific gangliosides, primarily GM1 or GD1A. Now, these are complex molecules found right on the surface of the axon membrane, and crucially, they're concentrated at the nodes of Ranvier, those gaps in the myelin sheath. So when antibodies and complement proteins deposit right there at the node, it leads to rapid, severe damage directly to the axon itself. It's not just temporary demyelination. This direct destruction is why C-glucosidase-associated GBS and the axonal variants generally carry a much tougher prognosis for recovery.
Right, because if the axon itself is destroyed, recovery depends on regrowth, which is notoriously slow and often incomplete. So flipping that, in the demyelinating form AIDP, what's the target there and how is the damage done?
In AIDP, the immune attack targets the myelin sheath itself, or the Schwann cells that produce the myelin. Here, the damage is less about direct antibody attack on the axon and more mediated by T cells. These T cells get into the nerve roots and the peripheral nerves, and they recruit macrophages. It's these macrophages that then actually strip the myelin away from the axon. The result is what we call segmental demyelination, leading to slowed nerve conduction or conduction block. But crucially, the underlying axon often remains relatively intact. This means recovery is generally quicker and more complete, because the goal is remyelination, repairing the sheath, not regrowing the whole axon. Understanding that difference is really fundamental when we interpret nerve conduction studies and predict long-term function.
This brings us right back to the clinical classification and how these different pathologies actually look at the bedside. Let's dig into the specific presentations a bit more.
Okay. AIDP, as we said, most common in the West. Pathology is segmental demyelination. Clinically, you see that classic picture. Symmetrical weakness, often ascending, sensory symptoms are common, and that profound areflexia, loss of reflexes. On the electrophysiology, the nerve conduction studies, you'll see evidence of that myelin damage slowed conduction velocities, conduction block. But then the AMAN variant, acute motor axonal neuropathy, that's purely motor, isn't it? Yeah, that's its defining characteristic, yes. It's a pure motor syndrome. It's often linked to those specific anti-GM1 and anti-G1 antibodies we mentioned. Patients present with rapid, severe motor weakness, sometimes incredibly profound. But, and this is key, they often have relatively preserved reflexes or only minimally reduced ones, especially early on. And importantly, minimal or no sensory loss. It reflects that pure attack on the motor axons. Nerve conduction studies confirm this. You'll see severely reduced amplitudes of the compound muscle action potential, the CMAP. That's the electrical signature of significant axonal loss.
And then there's AMSAN, acute motor sensory axonal neuropathy. You mentioned this carries the worst prognosis.
Generally, yes. AMSAN shares that same destructive axonal pathology as AMAN, but the attack isn't limited to motor fibers. It hits the sensory fibers too. So this leads to profound deficits in both motor and sensory function, making recovery particularly challenging. The prognosis is usually worse than either AIDP or AMAN because you're relying on that slow, often incomplete axonal regeneration for both systems.
We should also touch on Miller-Fisher syndrome, MFS. It's an atypical variant, but one that can definitely throw clinicians off if they're not looking for it.
Right, MFS is rare, but very distinct. It's strongly associated with antibodies against a different ganglioside, anti-GQ1B. Clinically, it presents with a classic triad: ophthalmoplegia, paralysis of eye muscles, ataxia, lack of coordination, and areflexia, loss of reflexes. The limbs might not be weak, but the involvement of eye movements and coordination, along with absent reflexes, should make you think of it. Recognizing MFS is important because the diagnostic approach and the treatment IVIg or plasma exchange are the same as for classic GBS.
Okay, let's pivot now to those critical clinical symptoms, the ones that demand our immediate attention in the hospital setting. Beyond that progressive bilateral symmetrical weakness, what are the really high-risk signs we need to watch for?
Well, areflexia or hyporeflexia, that's the hallmark. If reflexes are brisk or normal, you should really question the GBS diagnosis. But beyond motor and reflexes, there are two non-motor factors that often dictate the entire acute hospital course: pain and bulbar involvement.
Tell us more about the pain. It feels like it's often under-recognized or underreported initially.
It's extremely common and often severe. It affects well over half of GBS patients. It can present as this deep, aching muscle pain, particularly in the back and limbs, or sometimes as burning or tingling neuropathic pain, dysesthesias. And it's not just uncomfortable, it can significantly interfere with sleep, with rehab efforts. It requires dedicated, often aggressive, pain management strategies.
And the cranial nerves, you mentioned up to 50% involvement. That sounds like it would have a massive clinical impact.
It absolutely does.
Yeah.
Cranial nerve involvement most commonly shows up as facial diplegia, that is weakness on both sides of the face.
Oh.
More dangerously, though, it presents as bulbar palsy. This means dysphagia, difficulty swallowing, and dysarthria, difficulty speaking or slurred speech. Bulbar weakness is a huge red flag. It signals a major risk for aspiration and is often a harbinger of impending respiratory failure. Any sign of bulbar weakness demands immediate transfer to an ICU setting.
Which leads us perfectly into the life-threatening complications that mandate that ICU transfer. We mentioned respiratory compromise, but let's get specific. Why does it happen and how fast can it progress?
Respiratory compromise is the most frequent life-threatening event, hitting 20–30% of patients. It happens simply because the muscles of breathing the intercostals between the ribs and the diaphragm get weak. The scary part is how insidious it can be. Patients often compensate for a surprisingly long time using neck muscles, accessory muscles. They can look okay, maintain oxygen saturation, right up until they suddenly fatigue and crash. This is precisely why we rely on objective measurements and have strict early intubation criteria. We can't wait for them to look distressed.
And the second major threat, autonomic dysfunction. You said this occurs in 20–70% of hospitalized patients. That seems even more unpredictable, maybe more dangerous, given the risk of sudden cardiac events.
Autonomic instability is terrifying, frankly. It represents a complete breakdown in the normal regulation by the sympathetic and parasympathetic nervous systems. This can lead to really profound and rapid heart rhythm problems, severe bradycardia, slowing of the heart rate, even sudden pauses or asystole, cardiac standstill. We also see these wild swings in blood pressure. They can go from dangerously high, a hypertensive crisis, down to profound, hard-to-treat hypotension, sometimes within minutes. And finally, something maybe less immediately lethal but still problematic is neurogenic bladder. The autonomic nerves controlling the bladder fail, leading to significant urinary retention, which adds another layer of management complexity.
Okay, moving into the diagnostic evaluation. So the suspicion starts clinically, right? Based on that rapid, progressive, symmetrical weakness, the decreased reflexes, peaking within about 4 weeks. But how do we confirm it? And just as importantly, how do we rule out the dangerous mimics?
Exactly. Clinical suspicion is first, but we rely heavily on ancillary tests to support the diagnosis. The first, and usually the easiest to get, is the cerebrospinal fluid analysis, the CSF, from a lumbar puncture. The classic finding we all learn is albuminocytological dissociation. Fancy term, but it just means elevated protein levels in the CSF, but with a normal or only slightly increased white blood cell count.
We need to emphasize the timing issue with CSF results, though, don't we? Because that often causes diagnostic headaches early on.
Absolutely critical point. The sensitivity of that finding is very time dependent. If you do the lumbar puncture on day 1 of symptoms, that dissociation might only be present in about half the cases, maybe 49%. It takes time for the protein to rise. The sensitivity climbs significantly, reaching its peak of around 88% only after about 2 weeks of symptoms. So a normal CSF early on absolutely does not rule out GBS. And a really important practical warning, if you do see a high cell count in the CSF, what we call marked pleocytosis, say, over 50 white cells per microliter, you have to strongly consider alternative diagnoses. Things like infectious meningitis, Lyme neuroborreliosis, even HIV seroconversion.
Okay, and the second key test for classification and prognosis is nerve conduction studies, NCS. When should we be pushing to get those done?
NCS are vital. They confirm that it is a peripheral neuropathy. And crucially, they help classify the subtype. Is it primarily demyelinating like AIDP, or is there evidence of axonal loss like an AMAN or AMSAN? This classification has major prognostic implications. Ideally, you get them done relatively early, but we all know the logistical challenges in a busy hospital. The absolute priority, though, is not to delay treatment while waiting for NCS results, especially if the patient is worsening rapidly. If the clinical picture strongly suggests GBS and the patient meets treatment criteria, like being unable to walk, you initiate therapy immediately. The NCS can follow when feasible.
This brings us to maybe the most crucial part of the initial assessment, the differential diagnosis. This is where hospitalists really earn their keep, right? Making sure we're not missing something else that needs totally different, maybe urgent management.
Absolutely. We have to systematically rule out the life-threatening mimics. Top of that list has to be spinal cord compression. If a patient presents with a very abrupt onset of paralysis, like flipping a switch, or if they have prominent urinary retention right from the start, or maybe most tellingly, if you find a distinct sensory level on their neurological exam, GBS becomes much less likely. In those cases, you must urgently rule out a compressive spinal cord lesion, think epidural abscess, hematoma, or tumor, that requires an immediate MRI and potentially emergent neurosurgical consultation. Missing cord compression is catastrophic.
What about conditions caused by toxins?
Botulism is the classic one there. Unlike GBS, which usually ascends, botulism typically presents with descending paralysis. It often starts with the cranial nerves, droopy eyelids, ptosis, maybe fixed dilated pupils, prominent bulbar symptoms like swallowing difficulty, and often severe autonomic problems very early on. The diagnosis is mainly clinical, and giving the antitoxin quickly can be life-saving, so recognizing that pattern is key.
And we also need to differentiate GBS from other inflammatory conditions, perhaps affecting the central nervous system.
Correct. Acute transverse pyelitis is a major consideration. This inflammatory condition of the spinal cord usually presents with a very clear sensory level on exam and often definite early sphincter dysfunction related directly to the cord lesion. Remember, in GBS, sphincter issues are usually due to autonomic dysfunction affecting the bladder, not a direct spinal cord problem. And finally, you might consider a myasthenia gravis crisis. This causes fluctuating weakness, typically worse with activity or later in the day. But the key differentiator here is that deep tendon reflexes are almost always preserved in myasthenia, unlike the profound areflexia characteristic of GBS.
Okay, let's transition now into the nuts and bolts of hospital management. Starting with that core supportive care, which, as you stressed, is absolutely critical for survival and preventing lasting damage.
Right. Management absolutely requires a coordinated multidisciplinary team. Neurology, ICU specialists, respiratory therapy, PT, OT, nursing. Everyone has to be involved from day one. All confirmed or highly suspected GBS patients need close observation. But any patient showing moderate or severe weakness or any sign of bulbar symptoms needs immediate transfer to a critical care setting for continuous intensive monitoring.
And the cornerstone of that supportive care is respiratory vigilance. Can you give us the hard numbers, the protocols for monitoring?
We need continuous objective monitoring of their breathing function. The key measurements are vital capacity, or VC, and the negative inspiratory force, NIF. Think of NIF as a measure of inspiratory muscle strength. These must be checked frequently, at least twice daily in stable patients, but often every 4 hours or even more frequently in someone who is rapidly progressing or borderline. The hard trigger points for considering early elective intubation are generally a vital capacity falling below 15 milliliters per kilogram of ideal body weight, or a NIF that becomes less negative than -20 to -30 centimeters of water. These objective numbers are crucial because, as we said, subjective dyspnea is unreliable. Also, any clear clinical signs of bulbar dysfunction, like difficulty handling the secretions, progressive rapid breathing to dyspnea, or falling oxygen saturation despite supplemental O2, those are also triggers to intubate electively before the patient tires out and crashes.
Why the strong emphasis on early and elective intubation?
Because performing an emergent intubation on a GBS patient, especially one who already has autonomic instability, is fraught with peril. It's highly likely to precipitate a cardiovascular collapse, profound hypotension, severe bradycardia, even a systole. This often leads to a much worse outcome, increased complications, higher mortality. Elective intubation in a controlled setting is far, far safer.
Autonomic management is that other really high-stakes challenge. How we even begin to approach the wild swings of blood pressure and the risk of these cardiac events.
Continuous cardiac monitoring, ECG monitoring, is absolutely non-negotiable throughout the acute phase until the autonomic instability clearly resolves. The blood pressure lability is incredibly difficult. For severe hypotension, we often need potent, short-acting vasopressors, usually things like norepinephrine or phenylephrine, given as continuous infusions that we have to titrate constantly, sometimes minute to minute, just to maintain adequate organ perfusion. It's critical to avoid long-acting blood pressure medications, whether for high or low BP, and avoid diuretics that deplete volume, because these can make the swings even worse when the pendulum inevitably shifts back. For the severe hypertensive episodes, we prefer short-acting, easily titratable intravenous agents like nitroprusside or esmolol. But we always have to remember, we're just treating the symptom, the number, not the underlying autonomic storm. And in patients who develop persistent symptomatic bradycardia or actual pauses, episodes of asystole, temporary cardiac pacing might become necessary.
Okay, beyond those immediate life threats, we have to manage the complications of just being profoundly weak and immobile right from the start.
Absolutely. DVT prophylaxis is mandatory. These patients are at extremely high risk for blood clots in the legs or lungs due to their immobility. This means using subcutaneous heparin or low molecular weight heparin, almost always combined with sequential compression devices or compression stockings. Additionally, we need to be really aggressive about managing that neuropathic pain we talked about. This often requires a multimodal approach, using agents like gabapentin, carbamazepine, sometimes NSAIDs, maybe even opioids cautiously, titrated carefully to provide relief without causing excessive sedation or respiratory depression.
And we also need to be thinking about mobilization, even passive range of motion, very early on.
Yes, absolutely. Early involvement of physical and occupational therapy is crucial. It should start as soon as the patient is medically stable enough, sometimes even while they're still intubated in the ICU. This involves passive range of motion exercises to prevent joint contractures, positioning to prevent pressure sores, and as soon as possible, progressing to active exercises to mitigate muscle deconditioning. The longer we wait, the more profound the deconditioning, and the longer and harder the rehab process becomes.
Okay, let's turn now to the disease-specific treatments. Immunotherapy. Who gets it, and what are our options?
Right, so immunotherapy is indicated for pretty much all GBS patients who are significantly affected. The standard cutoff is patients who are unable to walk 10 meters unaided. That's a major functional benchmark. Or it's indicated for any patient who is demonstrating rapidly progressive weakness, even if they can still walk, because the goal is to halt the progression and shorten the duration and severity of the illness.
And we essentially have two main options, both considered equally effective, that speed up recovery. Intravenous immunoglobulin, IVIg, and plasma exchange, PE, also called plasmapheresis. How do we choose between them in practice?
That's right. Multiple large trials have shown that both treatments offer comparable efficacy. They both reduce the time it takes to recover motor function, reduce the need for ventilation, and limit overall morbidity. So the choice often boils down to practical factors. What's available at the institution? What are the logistics? Are there specific patient contraindications or potential tolerability issues?
Can you give us the specifics on IVIg first?
Sure. The standard IVIg regimen is a total dose of 2 grams per kilogram of ideal body weight. This is typically divided up and given over 5 consecutive days, so 0.4 grams per kilo per day for 5 days. IVIg is often favored in hospitals that maybe don't have apheresis capabilities because it's logistically simpler, just needs standard IV access and administration protocols. Crucially, IVIg is often the preferred choice in children and also in adult patients who are already showing signs of severe autonomic instability. This is because it generally has a better safety profile when it comes to causing acute hypotension during the infusion compared to the fluid shifts seen with plasma exchange.
Okay, and what about plasma exchange? What are the logistics and the clinical trade-offs there?
Plasma exchange, or PE, typically involves performing about 5 exchange sessions spread out over roughly 2 weeks. The goal is to exchange a total of about 5 plasma volumes over that period. PE is highly effective, but it requires specialized apheresis equipment, trained personnel, often nephrology or a dedicated apheresis team, and requires good, reliable vascular access, often meaning a temporary central dialysis-type catheter. The major clinical caveat, the big warning sign for PE, is that it should generally be avoided in patients who have severe labile autonomic instability. The significant fluid shifts and potential for procedural hypotension during the exchange process itself can be really dangerous, potentially precipitating cardiovascular collapse in these already unstable patients.
And we need to be very clear about what the evidence says regarding using both treatments sequentially.
That's simple and definitive. Combination therapy, doing plasma exchange, and then immediately following it with a course of IVIg offers no additional clinical benefit compared to using either therapy alone. So it's not recommended. It just increases risks, costs, and logistical burden without improving outcomes. And one other thing not to do. Corticosteroids. Steroids, when used alone as the primary treatment for GBS, have been shown in multiple trials to be ineffective, and they are not recommended.
Okay, moving towards complications and prognosis, let's quickly revisit those highest risks that have to stay front and center for the hospital team.
Number 1 is respiratory failure. Occurring in that 20–30% range, it's the most common immediate life threat, and it's also the single strongest predictor of both mortality and poor long-term functional outcome. Running a close second is that unpredictable autonomic instability. The constant threat of sudden, unexplained cardiac arrest due to those wild blood pressure swings, severe bradycardia, or even episodes of asystole.
And then we have the secondary complications, often related to the severity of illness and the prolonged hospital stay itself.
Exactly. Infections are a major cause of death in GBS patients, even in modern ICUs. Specifically, sepsis, often from hospital-acquired infections, and pneumonia. Aspiration pneumonia is a huge risk, especially in those with bulbar weakness. Hospitalists also need relentless vigilance for thromboembolic events, DVTs, and pulmonary embolism. We mentioned prophylaxis, but the risk remains high throughout the period of immobility, reinforcing why those protocols must be strictly adhered to.
Looking now at the recovery trajectory, what can we realistically tell patients and their families about the prognosis?
Well, the overall narrative is, fortunately, cautiously optimistic for the majority. Most patients, somewhere around 77 to 81%, do eventually regain the ability to walk independently, usually within 6 to 12 months after onset. However, that leaves a significant minority. Up to 20% of survivors experience persistent, often substantial disability at the 1-year mark. They might still require walking aids, wheelchairs, or ongoing support for daily activities.
And are there key factors we can identify early on that help us predict who might fall into that poor outcome group?
Yes, several factors are consistently associated with a tougher course and less complete recovery. These include advanced age at onset, the severity of limb weakness when they first present, needing mechanical ventilation at any point during the illness, having one of the axonal subtypes of GBS, AMAN or AMSAN, confirmed on nerve conduction studies, and having had that antecedent Campylobacter jejuni infection. Recognizing these factors early helps us risk stratify, tailor the intensity of rehab, and maybe most importantly, set realistic expectations with the patient and family.
That significant chance of persistent disability really underscores the importance of the long view, rehabilitation and long-term management. It sounds like the principle here has to be early, intensive, and sustained intervention.
Absolutely. Rehabilitation shouldn't be viewed as something that just starts after discharge. It's an integral part of the acute care phase. Physiotherapy and occupational therapy consults should happen as soon as the patient is medically stable, even if they're still in the ICU, even during the nadir phase, when weakness is maximal. The initial focus is on preventing complications, contractures, pressure sores, maintaining joint mobility, mitigating muscle atrophy. Respiratory physiotherapy is also vital for patients with residual bulbar weakness or generalized respiratory muscle weakness, helping with secretion clearance, breathing exercises, and facilitating weaning from ventilation if applicable.
And the intensity and duration of this rehab phase seem to really matter for the final outcome.
That's what the evidence strongly suggests, yes. Studies have shown pretty clearly that patients who receive dedicated inpatient rehabilitation followed by sustained outpatient physiotherapy, often for periods longer than 6 months, achieve statistically and clinically significantly better long-term functional outcomes, particularly in terms of walking ability and independence compared to those who get less intensive or shorter durations of therapy. It really highlights the need for robust post-acute care planning and resources.
So what should be the key focus areas for long-term follow-up, especially for that 20% or so who face ongoing challenges, but maybe even for those who seem to recover well initially?
Ongoing multidisciplinary follow-up is really essential, particularly for those with clear, persistent disability. But even among survivors who regain independent walking, we know that the two most common and impactful residual symptoms are persistent, often subtle, weakness, and maybe even more significantly profound, debilitating fatigue. This post-GBS fatigue can be overwhelming and often dictates their ability to return to work, engage in social activities, and maintain their previous quality of life, even if their objective muscle strength seems pretty good.
So long-term management has to go way beyond just checking muscle power scores. It needs to include dedicated strategies for managing chronic neuropathic pain, which is a frequent long-term sequelae, and also proactively addressing the psychosocial impact, the distress. Surviving GBS often involves periods of intense fear, total dependency, loss of function. That psychological toll needs to be acknowledged and managed as a critical part of comprehensive follow-up care.
So just to summarize the key points from our deep dive today, successful hospital management of GBS really hinges on recognizing the high-risk patient the moment they present, ensuring that seamless and rapid transfer to critical care when indicated, implementing absolutely rigorous respiratory and autonomic monitoring protocols, and then initiating IVIg or plasma exchange without delay for appropriate patients to limit the extent of the immune attack.
The sheer volatility and complexity of GBS demand more than just reacting to crises. It really necessitates proactive planning for the potentially long and challenging road to recovery that lies ahead for these patients. We almost need to integrate those long-term recovery considerations right into the acute phase of care.
Which leads to a final thought, perhaps. Considering the profound and persistent symptoms we know many survivors report, particularly that crushing fatigue and chronic neuropathic pain, even among those who regain the ability to walk independently, what are the immediate concrete steps a hospital team, specifically thinking about the hospitalist, the case manager, the discharge planner, can take before the patient even leaves the hospital. How can we proactively plan for and begin to address this significant long-term burden during that initial hospitalization? Getting ahead of these issues, structuring that sustained, multidisciplinary follow-up from the outset. That feels like the next frontier in providing truly holistic and effective care for GBS survivors.